looking at barriers and opportunities in this space, which hopefully will lead on nicely to Sarah and Tom's presentation, which I'm very excited to hear about. So, look, it's no denying that vaccines are the most effective way of preventing infectious diseases and saving lives. So 50 years ago, the World Health Organization launched the expanded program for immunisation in the context of global rising rates of vaccine-preventable infections. And over this time, this has resulted in 154 million lives saved, and 40% of the global reduction in infant mortality is attributable to vaccination. And this is the biggest single contribution to the prevention of deadly infections. So we're very lucky in Australia to have a very robust, nationally funded immunisation program beginning from birth, continuing through infancy, into adolescence, and then, of course, an adult and pregnant women program as well. So by the time a child reaches adolescence, they're protected against some, if not all forms of these 11 viruses and 6 bacteria listed here, with, of course, the new addition of the RSV pregnancy vaccine this year. And in a more global context, or for children travelling overseas, there are additional vaccinations and that are listed here against typhoid fever, tuberculosis, malaria, cholera, Japanese encephalitis, yellow fever, and dengue, and with some really pleasing progress in the malaria and dengue vaccine development space recently, although the malaria vaccine rollout has, of course, been impacted by UN aid cuts. So now looking at the impact of vaccines on antimicrobial stewardship. I don't have to explain this in great detail to this audience. You're all maybe very aware of the mechanisms by which vaccines can impact antimicrobial resistance and antibiotic use. But, you know, thinking more broadly, this perhaps isn't as widely appreciated in the medical space and popular literature. So you can see here in the in this diagram, vaccines reduce the rate of infections. They also, therefore, reduce the rate of secondary bacterial infections requiring antibiotic use. They also, some vaccines can impact transmission and therefore protect the community through herd immunity. And so this reduction in antibiotic use suppresses resistance evolution, means our antibiotics remain more effective and decrease the individual risk from resistant pathogens. And so in this kind of context, the WHO came up with this action framework in 2021 to leverage the use of antibiotics. And it was centered around these 3 strategic goals: to expand the use of licensed vaccines to maximize the impact on antimicrobial resistance, develop new vaccines that contribute to prevention and control of AMR, and expand and share knowledge of vaccine impact on AMR to help advocate for further investment and really highlight the full value of vaccines. Whoops. So for action point 3, WHO came up with this report, which is estimating the impact of vaccines in reducing antimicrobial resistance and antibiotic use. This was released in October last year, focusing on 24 pathogens and looking at scenarios for 44 vaccines that are either licensed, in clinical development, or hypothetical vaccines. So it's a really rich report. It quantifies the potential for these vaccines to reduce AMR, its effects on an antibiotic use, and it does focus on human vaccines, but similar analyses could be done for animal vaccines. It's really hoping to provide a resource for many policymakers, researchers, funders in the vaccine space. So in terms of headline findings of the report, they found that currently licensed vaccines could avert up to 106,000 deaths associated with AMR and reduce antibiotic use by 142 million defined daily doses annually if coverage is expanded. And every year, vaccines against strep pneumo could save 33 million antibiotic doses if the immunisation agenda 2030 target of 90% of the world's children were vaccinated, along with older adults. Typhoid could save 45 million antibiotic doses if the introduction was accelerated in high-burden countries. And Plasmodium falciparum malaria vaccines could save up to 25 million antibiotic doses, which are often misused to treat malaria. So you can see also the theme here around expanding coverage and the need to work on access. And then TB could have the highest impact, saving between 1.2 to 1.9 billion of the 11.3 billion antibiotic doses used annually against diseases that are covered in this report. So they provide these tables. I don't expect you to be able to read this, but this is an example of one of the summary tables where they're looking at the estimated and potential vaccine impact on AMR annually for the vaccines with a high feasibility of development and delivery. So for these pathogens, strep pneumo, MTB, Salmonella typhi, Haemophilus influenza B, influenza, Plasmodium falciparum, rotavirus, RSV, and gonorrhea, can see significant impacts here on vaccine averted deaths associated with AMR, averted disability adjusted life years, vaccine averted antibiotic use, hospital costs, and productivity losses. So significant impacts. There are limitations in modelling reports, definitely, but this is probably also an underestimate because they didn't consider the long-term effects of things like stunting from typhoid or effects from rheumatic heart disease in the context of group A strep vaccines, which they also looked at in this report. So just to look at strep pneumo more specifically, so this is a study of a vaccine, the pneumococcal conjugate vaccine we've had for many years now. So this was looking at data after introduction of PCV between 2000 and 2020, looking at a large number of paediatric isolates, over 300,000, and the antimicrobial susceptibility profile since introduction of the vaccines. And you can see here in this table, there has been an impact on reducing the rate of penicillin, Bactrim, and third-generation cephalosporin non-susceptible isolates. And then, of course, I thought it would be important to focus specifically on RSV and the potential impacts on antimicrobial use and stewardship in our current context of this being scaled out nationally. So RSV has a significant impact on infant hospitalisation, causing deaths in young infants in particular, worldwide, over 100,000 deaths a year in the 2019 Global Burden of Disease report. And this is particularly affecting young infants in low and middle income countries. So we all know as healthcare workers that antibiotics don't treat viral infections, but when you're presented with a child with a lower respiratory tract infection, it can be difficult to distinguish between bacterial and viral infections. There is, of course, fear around missing a secondary bacterial infection. So there's a lot of inappropriate antibiotic prescribing for lower respiratory tract infections caused by viruses such as RSV. And so the modelling in the World Health Organization report suggested that there is 29 million doses of antibiotics used for RSV-related illnesses annually, and that the impact of a maternal vaccine with an efficacy of 70% and a coverage of 70% and a duration of effect of 6 months would avert 3.9 million doses of antibiotics. This effect would be amplified if we had a vaccination for children with a duration of protection of 2 years, as opposed to the monoclonal antibody programs, which is passive immunisation with nirsevimab. So this modelling, shows that the antibiotic doses would be reduced even further, but at the moment, childhood vaccine programs have been halted while there's further analysis of the RSV pre-fusion F clinical trial results from the Moderna trial. So there's been some media interest in looking at this modelling around reducing antibiotic use after introduction of RSV vaccines, with a couple of examples of modelling studies out of the UK, the one on the right suggesting that perhaps the cost effectiveness of RSV vaccine strategies in England would likely not be altered by integrating the benefits of preventing drug-resistant infections in addition to RSV disease prevention. We've also got these post hoc analyses of clinical trials of the Harmony infant nirsevimab program, and then the Novavax pregnancy vaccine, which isn't as efficacious as the currently licensed VIRGo vaccine. And you can see here there were significant reductions in presentations with lower respiratory tract infections and antibiotic prescriptions. So I think we wait with bated breath for the answer to this question. Will RSV vaccination do more for AMS in children than any dedicated AMS intervention? So then just in the last 15 minutes of my talk, leading on to Sarah and Tom, I want to cover where we're at with childhood vaccine preventable diseases. And of course, there are many factors that influence the current state of these diseases. So we do have declining coverage, particularly since the onset of COVID-19. We have changing epidemiology of pathogens. There are access barriers, which are less so of an issue in Australia compared to the global context. And then there are individual vaccine considerations. So I will just run through examples with influenza, invasive pneumococcal disease, and pertussis. So this is looking at influenza. So influenza can cause severe illness and death in otherwise healthy children. Unfortunately, coverage of the free annual influenza vaccine from 6 months to less than 5-year-olds is reducing. So in 2020, we had a coverage rate of 44%. In 2024, it was 25%. And we can see here in the national disease surveillance data that the influenza rate has been rising over the past 2 years. An invasive pneumococcal disease being most common bacterial cause of childhood meningitis, associated with significant morbidity and mortality. The coverage actually is holding. So from 2020, we had coverage rates of 96.5%. 2024, it is a slight reduction down to 95%, but coverage for pneumococcal vaccines is above the national coverage rate of immunisations, which sits at 90% from the 2023 report. So encouragingly, this vaccine has good uptake, and we're seeing kind of stable rates of invasive pneumococcal disease over the past few years. And then pertussis. So many of you will be aware of the epidemic of pertussis that began last year, with the highest recorded number of pertussis infections since we started recording pertussis notifications in 1991. And this is in the context of only 1 in 4 adolescents receiving their booster. Sorry, that's a typo on my slide there. So declining coverage rates, rising rates of pertussis. But this also, the fact that there has only been 2 deaths in infants over the past several years from pertussis shows us the impact of pregnancy vaccination in preventing severe disease in infants. And then measles. There has been public health alerts of measles cases in Australia. This is in the context of outbreaks occurring in many countries around the world, and children can receive their measles vaccine early, as young as 6 months of age, if they are travelling to these countries. So why are we seeing declining rates? This has been a topic of the National Vaccination Insight Project survey, which was delivered to 2,000 parents as part of this collaboration with NCS, MCRI and the University of Sydney. So the headline findings for this report were that there were multiple barriers, but a significant barrier for parents was the feeling of being distressed when thinking about vaccinating their child, so an acceptance barrier, and also a couple of access barriers, but we look forward to the final report and recommendations which are due to come this year. And of course, we have the NCS coverage reports, which provide good insight into these barriers as well. And there are individual vaccine considerations as to why we're seeing breakthrough infections for vaccine preventable diseases. So for pneumococcal disease, our current NIP funded vaccine is the pneumococcal 13, PCV 13 immunisation. But there are, of course, 100 serotypes of pneumococcal, and non-PCV 13 serotypes contribute to 40% of childhood invasive pneumococcal disease cases. But we do also see breakthrough infections of serotypes that are covered in the pneumococcal conjugate vaccine. And there is currently a broader PCV incorporating 20 serotypes of pneumococcus, which is TGA approved, not yet NIP funded, and there are phase 3 trials underway for a PCV 21 vaccine, which includes an increased antigen against serotype 3. But of course, a serotype agnostic PCV vaccine is not yet in late stage development. And then thinking about pertussis, we currently have an acellular vaccine available in Australia. But unfortunately, this is associated with waning immunity and limited impact on transmission. There are trials looking at a combination of acellular and whole cell vaccine schedules. And there is also a phase 3 trial to commence of an intranasal live attenuated pertussis vaccination, which should limit infection and transmission. So we must use every tool at our disposal to continue to develop, improve and deploy these miracles of science. It is a matter of the most basic human justice that we do all we can to extend these life-saving interventions around the globe. So this is what Bill Gates wrote in the foreword to seminal vaccine textbook. And just touching on some global pipelines and global strategies to address both individual vaccine, but also access issues. So it's really exciting that we have a new TB vaccine, phase 3 trial of the M72 AS01 vaccine in adolescents and adults commenced in March 2024. It'll be really exciting to see the results of this trial and the impact on TB and drug-resistant TB. And then another strategy is vaccine microarray patches, which will increase coverage by hopefully increasing acceptability, but also addressing logistical issues around cold chains in the global context. But this has a little bit of a way to go. And of course, there are many other vaccines in the pipeline, such as a Group A strep vaccine, but I won't go into that today. So to conclude, childhood vaccines are life-saving tools with significant impact on antimicrobial use. Vaccine use and access and implementation of new vaccine programs provide challenges and opportunities, which we will hear more about from Sarah and Tom. So thank you very much.
Thank you for the very informative presentation, Yara. We'll open the floor for any questions. Please feel free to use the Q&A box to type in your questions. But while we wait for some questions, Yara, I might ask you around the navigation around vaccine uptake and how to address or what resources or education is available for vaccine hesitancy or vaccine hesitant parents.
Yeah, it's a great question, Josephine. It's a very hard question. We have, but we do have lots of available resources through, I think the NC's website provides, probably the best resources around this, especially their work around the addressing vaccine access barriers and the survey that I mentioned. I think that will provide really tailored outputs and recommendations to specifically address, misinformation that we're seeing in the context of COVID-19. And yeah, I'm really looking forward to that report and hopefully addressing some of those concerns for parents.
Yeah, I was just wondering, is it routine in terms of paediatric care, both in primary and the hospital setting, just like we have sort of quite set programs, warden feedback around antimicrobial use and stewardship? Are there any vaccine stewardship models that have been thought about? Maybe you're in a quaternary hospital, so obviously you're very well resourced, but you must have thought about this, how do you address it in a systematic way?
Yeah, great question. So in our setting at RCH, we have on our, when you open up a patient dashboard, we're lucky enough to have Epic. One of the first things that you see is the child's vaccine status, so where they're at with their immunisations, to provide, a record and an opportunity to address that. And it's always part of our routine history taking in paediatrics, are the immunisations up to date? And so you're thinking in terms of capturing that systemically, and what are you thinking specifically, Kaz?
I think I guess in terms of antimicrobial stewardship, we tend to have a stepwise approach or a triage approach, and we try and address the patients most at risk that haven't been. So, for example, at Paediatric, Ben Tay has established a vaccine pathway for the high-risk hematology patients, which is nurse practitioner-led, but it follows, follows a pathway, and that's increased compliance really well in the highest risk group of patients. So just an example of something you can set up as a system. So obviously with children, they'd be the same, there'd be those kids that are at particular risk that needs that particular sort of more considered approach to ensure that vaccines are given on time and that barriers to administration are addressed.
Yeah.
And that's not going to be for every child, but I'm sure there would be children who, and of course we see even in adults, those patients that should have had vaccine, influenza vaccine, repeat COVID vaccine. There is a lot of misinformation out there. So
yeah, I think
definitely a challenging space.
Yeah, it's challenging. I think as paediatricians, it is part and parcel of our role to advocate for vaccines and target those high-risk groups, as you say. And yeah, there's definitely opportunities. And as I said, with Epic, it is, there are opportunities to see which child is missing their vaccine. And we often will, if a 6-week-old is admitted, for example, due for their vaccines, we will do that on their way out after being discharged. So it is a big and important focus in paediatrics for sure. And it's great that Ben's following that through in high-risk adults. Good to hear them.
Might move on to our next two speakers. I'll introduce to everybody our next two speakers, Sarah Risdale and Thomas Clayton. Sarah currently works as an advanced pharmacist within the clinical team at the Queensland Health Immunisation Program, and she provides clinical support for a number of programs such as RSV, influenza, and Mpox. And Tom is the current Assistant Director of Clinical Governance and Workforce for the Queensland Health Immunisation Program. He is an experienced paediatric hospital pharmacist with over a decade of experience across various tertiary paediatric subspecialties. I'll hand over to you both, Tom and Sarah.
Perfect. Thanks so much, Josephine. Can you guys hear me? Excellent. Thank you very much. And thanks, Yara. This is a really nice segue into our what we'd like to talk about today. So Sarah and I are going to be speaking about Queensland's Paediatric RSV prevention program. So this is a relatively new program for Queensland, which launched in 2024. So Sarah, yes, is, as you've heard from Natalie, is a colleague of mine. We're both pharmacists, and you know, we played a role in developing Queensland's RSV nirsevimab program in 2024, and we'd like to share with you some of our learnings and some of our key challenges and successes of that program. But I would like to sort of start off by providing a little bit of a brief history about RSV and why it's such an important infectious disease in young children. Sarah's controlling the slides today, and she's from home and I'm at work. So Sarah, would you mind going to the next slide? Thank you. I would like to start by acknowledging the traditional custodians of the lands and waterways in which we live, work, and play. Here in Brisbane, that's the Turrbal and Yagara people, and I would like to pay my respects to their elders past and present. I think it's a really important thing to acknowledge that Aboriginal and Torres Strait Islander children are burdened by RSV disease at a rate of 2 to 3 times more than non-Indigenous children. So it is critical that we focus our work on trying to prevent RSV disease or ensure that there is culturally appropriate and safe prevention options for RSV disease, including as part of this program I'm going to speak about today. Next slide, please, Sarah. Thank you. So, like, as I said before, I'm sure most people are aware, thanks. RSV is probably one of the most significant pathogens in early childhood. It's a really common cause of bronchiolitis and pneumonia in infants under 6 months. And like I spoke before, Aboriginal and Torres Strait Islander children 2 to 3 times more likely to be hospitalised with severe RSV. By the 2nd year of life, most infants have been infected with RSV at least once, and it is the most common reason that infants in their first year of life will need care in hospital. The high-risk groups, well, most of the hospitalisations with RSV occur in otherwise healthy infants, so 70 to 80% of hospitalisations in Australia with RSV are in otherwise healthy infants, but of course, those children with medical comorbidity such as prematurity and including Aboriginal and Torres Strait Islander children have a higher burden also. There is emerging evidence that early infection with RSV has some longer implications. An INSPIRE study in the US did show that no early infancy RSV infection was associated with a 26% reduction in asthma diagnosis by 5 years of age. So, it's a really ubiquitous common virus, and prior to 2024, there wasn't really a great deal we could do about it. I will speak briefly around the small specialised prevention strategies that we've had in Australia, mainly with Pavedumab briefly, but really other than that, from a whole of population infant protection program, there hasn't really been anything available. Maternal antibodies do provide some protection for disease through maternal natural immunity, but it's certainly not enough to provide substantial or longer lasting protection against RSV. RSV traditionally occurs seasonally, particularly in more temperate environments. So that's in areas, for example, in Australia, more of our southern states where there is really defined increase in RSV notifications across those winter periods. But for example, here in Queensland, in the more tropical areas, that season really is protracted. We're seeing RSV earlier and later, and it does occur all throughout the season. Next slide, please, Sarah. Thank you. So this is RSV became notifiable in Queensland in 2021, as alongside with many other jurisdictions in Australia. Prior to that, we didn't really have really strong RSV notification data, but this really paints a really clear picture around where the RSV notifications sit. So this is data from Queensland in 2023, and you can really see that the notifications per 100,000 per year is really defined in those first few years of life, particularly in the first year of life, and a substantial reduction in that notifications occur sort of beyond the 5 years of cohorts, and then we can see in the older cohorts from the 70 years plus, it's beginning to rise again. But really, it's largely a disease of infancy at this point in time. Next slide, please, Sarah. So RSV prevention therapies had a bit of a rough trot, as Yara has mentioned. You know, we've probably heard in the news that Moderna's paused a lot of its RSV infant vaccine candidates just recently. But, you know, RSV was really only discovered, human RSV, in the middle part of the 20th century, so 1956. You can see from my little timeline slide. And, you know, not too long after that, in the 1960s, I believe it was, their first attempt at a paediatric RSV vaccine was made, a formalin inactivated vaccine. But unfortunately, that also wasn't particularly successful. That actually conferred more severe disease in those who were exposed to the vaccine compared to others. So that was quickly decided not to be an approach to be explored. It was a number of decades later that you know, there was a intravenous immunoglobulin product for RSV that was being studied, and this was in the 90s, and that was for more high-risk infants for RSV disease. But there was a number of issues with that. This was a human pooled, large volume intravenous infused product for high-risk infants of RSV. But it turns out that the efficacy of the product was quite poor, and it was associated with things like infusion reactions and obviously the complexities of administering those products intravenously. In the late 90s, we saw pavoluzumab came along. So that was the first monoclonal antibody specific for RSV. So that came in 1997, and we've been using it here in Australia for the best part of 20 years, really as our only solution for infants who are at high risk of severe RSV. And I'll speak a little bit more about it, I believe, in my next slide. There was another monoclonal antibody, which was a supposed improved version of pavoluzumab, but we didn't see much traction or it registered here in Australia. But of course, now we have a much more powerful monoclonal antibody product, which I think I speak on my next slide, please, Sarah. So the prevention landscape currently, like I've just spoken about, you know, we have seen pavoluzumab used quite broadly across Australia for registered for infants less than 2 years of age with complex medical conditions at risk of severe RSV. It does show modest efficacy, about 50 or 60% reduction in severe RSV hospitalizations, but there was a number of setbacks for pavoluzumab. One primarily was the cost, and it did require, it had quite a short half-life, and it did mean that it needed to be dosed monthly by intramuscular injection. So there was a number of barriers for use for that, and certainly it was defined to those specialised cohorts. In 2023, the TGA registered nirsevimab, so Sanofi's new RSV antibody. That's been registered for infants and young children under 24 months here in Australia. That was a substantial change in the RSV prevention landscape, and Sarah will speak a little bit about how we've incorporated nirsevimab into our program here in Queensland, and as has many other Australian jurisdictions for this year. We've also seen some new RSV vaccines come onto the market. So two new TGA registered vaccines, Arexvy and Abrysvo. Arexvy is GSK's product and was the first RSV vaccine registered in Australia for people 60 years and over, not funded under the National Immunisation Program currently, and is available on the private market. And of course, everyone will be aware of Abrysvo, which is also registered for 60 years and above, but has also just recently on the 3rd of February received National Immunisation Program listing for use in pregnancy. So Sarah, can we talk to the next slide, please? Oh, this is your slide. Thank you.
Thanks, Tom. So if you remember back to last year, you may recognise this table. It comes from the original target statement that was released regarding RSV prevention, particularly in infants and young children, and risk stratified those at highest risk that should be considered for nirsevimab, because at the time there was quite limited supplies and some states and territories were unable to access stock. So there was some information put out about who should be considered first or highest risk for the product. And in terms of developing the program, things we took into account at the time were the key public health and governmental priorities, thinking about what was most important for us in our state and protecting the people in our state. For the first time, we had a potentially cost-effective option to help reduce pressure on our hospitals, particularly those paediatric beds. We would normally take into account peak body clinical recommendations, but at the time we were developing this program was prior to the official ATAGI statement and clinical advice produced in the Australian Immunisation Handbook. So we were looking primarily at data coming out of the United States, the United Kingdom, Europe, places running their programs already. And we also had to take into account our unique state epidemiology. So as Tom mentioned earlier, in the more tropical areas, we can see year-round cases of RSV, and in Queensland, we're already starting to see increases in our cases now, well in advance of winter. So we do tend to get, particularly in the northern part of our state, a much more steady rate of RSV cases compared to those really dramatic winter peaks in the southern areas. So looking more specifically at our state, and I do acknowledge this is very specific to our program, but what the things we really thought about when we were developing the program. So we did a horizon scan. We looked through the data, the studies, what other countries were doing, what other agencies had approved, and what was really happening here in Queensland. We did a lot of planning around what it could look like, how many people we could cover with the doses that might be available to us, whether other jurisdictions were going to run similar programs. And prior to our program being announced, I believe WA had announced theirs. Whether we could get funding or had a budget within our state budget to roll this out, and what it could look like across our state, being quite a large state logistically to get stock from one end to the other in a very short time period. And we were also thinking about rolling this out right in the middle of our flu rollout, which is our busiest and biggest time of the year and often comes off the back of the wet season. So it can be very challenging for us here in Queensland. And we were really lucky. We were able to get the funding for this program and purchase the doses to help with our RSV rollout. And our Premier got up and announced it, and it was great. And everyone was very excited, but it left us with 2 weeks to develop and roll out this program. And that was the first time we could actually reach out to our peak clinical bodies, talk to our obstetricians, paediatricians, infectious diseases specialists, primary care providers about what this is, what it could look like, what we need them to do. So a lot of meetings with a lot of stakeholders very quickly, clinical guidance, consent forms, parent and carer fact sheets, all of that kind of stuff, whilst developing a rollout plan, getting our stock into the warehouse, getting it out of the warehouse and into provider fridges, giving providers enough support to be able to confidently deliver the immunisation to infants, particularly in the birthing space, and helping them to manage their time, because they're all very busy. We're asking them to do something new in a very quick time. So we had a lot of work to do, but we managed to get there. And this was the first baby in the state to receive the RSV monoclonal antibody, which was really exciting for us. And then moving forward, we continue to monitor our stock, and we're moving into that, really looking at the impact that it's had on our hospitals, and what we can do moving forward as we start to transition into that national immunisation program with the maternal vaccination of VIRGo now available. We actually rolled ours out slightly ahead of the national immunisation program to conserve our supply of nirsevimab so that we didn't have gaps for those really medically at risk infants that needed that stock. So what we developed in terms of our program. So initially we started with just the birth dose program through our birthing private and public hospitals back in April of last year, and then rolled that out about a week later to our primary care providers, just to really be able to mop up those children that missed it at birth. We provided a catch-up for all Aboriginal and Torres Strait Islander infants under 8 months of age, and all medically at risk infants less than at the time 20 months of age, because we didn't quite have enough stock to go up to a 24-month of age cohort, but now we're offering that up to the 24 months of age. And then, apologies, in in December of last year, we moved into our hybrid program using nirsevimab and the maternal vaccine of VIRGo, and that's now available widely across the country. All states have and territories have access to the maternal vaccine, and all states and territories are running some sort of infant nirsevimab program as well. And I've just put a note at the bottom that really both of these strategies rely on passive immunisation to protect the infant. Whilst we are using a vaccine in the maternal space, they're both still passive products. And I've tried to capture both the products in one slide just to make it a little bit easier for everyone. So we've got our nirsevimab, which is our long-acting monoclonal, provides protection for at least 5 months, but some of the anecdotal data that we're seeing, and hopefully more stuff will be, released and published soon. We're thinking it may be actually providing protection up to 12 months, which was really great. And then our maternal vaccine of VIRGo offers about 6 months protection to the infant from birth. In terms of efficacy, they're both quite similar in reduction of RSV, lower respiratory tract infections. Nirsevimab, slightly higher efficacy for prevention of severe RSV, lower respiratory tract disease, but pretty much on par in terms of the protection that they offer. They can be a little bit confusing for providers, and we're seeing this problem come in across the country, not just our state, in terms of which product do I give to which person, which product is the infant product, which is the maternal product. So we've been doing a lot of work with our providers around that to really make it clear that the antibody is for the baby, and that the vaccine is for the mum. In terms of the dosing, it's age and weight based for the nirsevimab, and then for the pregnancy vaccine, it's a single dose per pregnancy. There is limited data around subsequent pregnancies, but at this point in time, the recommendation based off other pregnancy vaccines is that they're likely to require subsequent vaccination in subsequent pregnancies. The biggest other key difference is that the nirsevimab does remain a state-based program, so each state and territory may have slightly different criteria for eligibility, but largely it's all really based off the Australian Immunisation Handbook recommendations. In terms of what we saw here in Queensland after we rolled out our program, and I do apologise, this slide has a lot of numbers on it, but we to date have sent out over 68,000 doses to our providers, and most of that has gone to our birthing program. We continue to offer nirsevimab non-seasonally in Queensland, particularly for that birthing program, and with the clinical advice that in the second year of life for the infants with risk conditions, that they consider whether they want to time that more closely to the RSV season. In terms of our uptake, we can see from our modelling that we believe it's around 70 to 80%, but we know this isn't well reflected on the Australian Immunisation Register. And this is not a problem specific to Queensland or specific to the RSV program. This is a national problem that we've seen across all jurisdictions, and it's a really hard problem to tackle, and we continue to work closely with our providers to try and improve that uptake to air. And it's obviously very important to ensure that the infants have a whole of life record, but also that we're not unintentionally administering nirsevimab to an infant that may not need it. In terms of our air data, we can see that at least 25,000 doses have been recorded to those under 1 month, and over 34,000 doses are recorded for children under 24 months of age. And our VIRGo program so far is going very well. We've had really, really strong demand in the maternal space for that. Mums really proactively going into their pharmacies, their GPs, all their primary care providers saying, I'm really interested in this vaccine, can I please have it? Which is really encouraging for us and really encouraging for our providers. And there has been a little bit of negative press, I guess, around the RSV vaccines in terms of those ones that Tom spoke about, which the clinical trials have been halted for, but there's also more recently in the last couple of weeks, you may have seen in the media a lot of stuff around the Guillain-Barré syndrome, and we've been watching that, but so far haven't had really any decreased demand or any really big concerns from our providers, so that's really reassuring. And once again, looking more specifically at Queensland, but what our RSV season looks like. And we've compared on the left 2023 and on the right 2024, which for us were quite similar seasons with maybe slightly more case notifications in the 2024 season. And what the main thing we really wanted to highlight with these graphs is that kind of darker blue line, which are under 6 months. So the biggest difference is in 2024, we had our birth dose program. We can see quite a dramatic reduction in the number of cases of RSV in that cohort, despite having slightly more cases. And we know there was probably a large number of people that were, weren't tested or didn't have a test when they presented with respiratory symptoms, which is not uncommon. And to really hone in on that younger age group, the under 6 months. And I think this is really the biggest success of our program, is that we've actually seen about a 48% reduction in hospitalizations for those under 6 months of age related to RSV. And this is really the most encouraging data that we have to show that our program is really making a difference on our hospitals. Speaking to our providers in the hospital space and our colleagues working in pediatric infectious diseases, that they have really commented that they did see a lot less RSV in that pediatric space last year, which is fantastic news and really what we wanted to see, and really on par with what we've seen from overseas programs. So we're really excited to see what happens with the maternal vaccine this year and what that looks like across the country, and continue to look at how we can help improve, the burden to the hospital across the state and the country. In terms of successes, it went as well as we could have hoped. We had our products out there. We were able to maintain the supply of product. We didn't run out. We sent out a large number of our doses to our over 800 providers, which was fantastic. Initially, we had about an 82% uptake, which was much higher than we thought. We had modeled it around a 70% in line with some of our other maternal programs. And as I said, we've seen that 48% reduction, which works out to be about a difference of 400 cases in a season, which is fantastic. And we were able to really do a lot of work with our providers and our stakeholders very quickly. We ran a number of webinars and engaged with them quite widely. And our challenges, as I mentioned, we didn't have an everlasting supply of stock, and we had to roll it out quite widely and very quickly. We did actually have a number of legislative barriers that we had to get through in terms of having a workforce that could deliver this product to people in a very quick manner. So doing some reforms around our regulations. And now really our biggest challenge is getting people to record to the air, but also managing that risk of vaccine administration errors, which we're starting to see. And there was a lot of hesitancy. I know we spoke earlier about hesitancy, but it is really a big issue, and it challenges all vaccines and immunisations and providers. And there was a lot of work to do. And surprisingly, there was actually some hesitancy from the providers themselves. This is a new product. And I think that's a bit of backlash from COVID as well. So it was a lot of work around, this is very similar to a product you've been using for a very long time. It's very safe. It's very important that, it is offered to people because it can really impact the life of their child. And as I said, that really short time frame. So where to from here? As I said, our data is really demonstrating quite a significant reduction on our severe pediatric disease cases, RSV disease cases, and which is really fantastic. And we're really hoping that we can see that on a national level. And we've taken a lot of feedback and done a lot of reflection on how this program was implemented, and really working this year to make our programs as big and the best that they can be. If you're interested in clinical resources on RSV, the Australian Immunisation Handbook has an extremely comprehensive chapter. You've already seen snips of the National Immunisation Schedule. Here in Queensland, we recommend our providers use the Queensland schedule, and each state and territory have their own version of their schedule that offers that includes the vaccines that they offer that are not covered under the National Immunisation Schedule. And we've heard the National Centre for Immunisation Research and Surveillance, NC, is fantastic. Lots and lots of stuff on there. And if you're in Queensland, we have our own website as well. I think that's it.
Thank you both to Tom and Sarah for your very informative presentation. Every time I thought of a question to ask, you seemed to answer it in the very next slide. I guess one thing you didn't, I guess, touch on is around the tolerability of the vaccine and whether there were any adverse events noted after administration. So I just wanted to quickly touch on that.
I can go if you want, Tom. So in terms of the infant products of the nirsevimab, really well tolerated, very limited feedback there's been adverse events or issues. The biggest concern or feedback we've had from providers around that particular product is how do we give it with both dose Hep B and the vitamin K? And that's what we really struggled with at the start, is how do you convince a mum to give 3 immunisations and how do you space it out? But really not a lot of adverse effects from that one. The maternal vaccine, we haven't really heard a lot, but I mean, in terms of the common side effects that we would expect, you know, fatigue, maybe a little bit of a fever or headache, aches and pains, just that really general stuff. Obviously, quite rarely they could have anaphylaxis or that Guillain-Barré syndrome. The data that came out of the States did seem to make it sound quite dramatic that like every person is going to get GBS, but it's not really that many more than we would expect, I guess, from other vaccines. But our providers are very good at talking through that, and it's been in our leaflet right from the start. It's been in the product information right from the start, so it wasn't really a big secret.
Thank you. And Kaz, you've got your hand up.
Yeah, that's amazing work and so impressive how you implemented and rolled it out. My questions relate to the next steps from a health services research point of view. Are you going to undertake a return on investment or health economic evaluation? I'm imagining it would be, I can imagine it'll be a very cost-effective program. And can you talk to a little bit about, you know, sustainability and ongoing funding? You know, we all know that these programs are going to under the vagaries of the government and health policies of each successive government. So interested in your thoughts here.
I'm
going to throw that one to
comment on
Tom.
that one if you like. Look, you know, like Sarah alluded to, we were really lucky to have really strong ministerial support for this program really early on. And like Sarah said, we rolled it out in about 4 weeks from when we knew that it was actually going to happen to when the first doses were being administered. But as part of that process, we undertook a pretty high level, theoretical economic evaluation around the cost of the product. We knowing how many pediatric RSV hospitalizations, the efficacy that was mainly coming out of Spain, in Galicia, and in the States, and we knew that it was likely to be cost effective. As for an evaluation for this program moving forward, it's we're hopeful that we're going to do a high level evaluation of the successes. As to the a detailed analysis and to justify it ongoing, well, you probably know that in an ideal world these sort of programs roll out in a nationally consistent approach, but on a more higher level, the issue is relating to nirsevimab is that it's not a vaccine, and we have a national immunisation program, but unfortunately non-vaccine products can't be assessed under the national immunisation program according to the National Health Act. So there's a number of pieces of work that are ongoing at the moment around, this is the first monoclonal product that has been used, universally, in an ideal world, we'd love to see things like this funded under the National Immunisation Program, but the state of play for 2024 is all the jurisdictions are funding their own nirsevimab, and the feds, the Commonwealth Government has come in and listed a maternal vaccine on the schedule. But it's a funny time. I don't suspect that will change anytime soon. I think and I think it's really important, the messaging that we're giving to the public and the comms around, there's 2 products. So for babies that are born to mums that don't receive the RSV vaccine are eligible for nirsevimab. But we want as many pregnant people to access the maternal vaccine as possible. But really the uptake of maternal Abrysvo will really dictate how much nirsevimab is used in each jurisdiction, if that makes sense. So we want the National Immunisation Program to be as efficacious as possible. I mean, it's really good because as soon as the baby's born, they've conferred protection, whereas with nirsevimab, it requires that to be given. If bub's really unwell, there can be things like delays and hesitancy around multiple immunisations at the same point in time at birth, which means they might go into the community and catch RSV while they're waiting to get the dose. So the maternal is absolutely the way to go. But, you know, I'm quite interested to see how this plays out over the next coming years with, you know, particularly over the next sort of 24 months as each state and territory is now funding their own nirsevimab programs to top up the bubs that are, you know, not conferred protection by maternal vaccine, or obviously in their second year who are medically at risk. I know that was a long-winded way.
No, it's great. And my follow-up question to that is, you know, we do see Queensland really impressively pulling together and doing really great statewide programs like the sepsis program, and, you know, jealous of how you can pull together and do things like that from down here in Victoria. But anyway, I guess it's that collaboration piece with colleagues from other states, and are you banding together as a collaboration to maybe drive a change in policy around it?
Absolutely. Yeah, so there's a national RSV working group which each state and territory sits on with the Commonwealth, and there's representation from ATAGI, and that has been in place for about 6 months now, and looks at the strategies and shared experiences with, you know, I mean, particularly from Western Australia and Queensland, we shared a lot of our learnings for nirsevimab with those groups, and that's a way of feeding back down through those jurisdictions on, you know, what worked, what were the successes. But, you know, where the Commonwealth is very aware that they're under their National Health Act, that's a significant issue, being able to consider vaccine products for a national immunisation program. And they did you may be aware of the HTA review, Health Technology Assessment Review, which reviewed things like the pharmaceutical benefits scheme process of listing things on the PBS using PBAC, and also the national immunisation program, because it goes through a PBAC approach. And there was a number of recommendations that came out of that to sort of streamline that process. And, you know, hopefully the Commonwealth will take that information on hand and you know, allow the national immunisation program to be more flexible, or more not reactive, more responsive to these new products coming on, when, you know, we might see new long-acting monoclonal antibodies for other infectious diseases, which we want to, you know, ideally we have a nationally consistent approach to these things.
Thanks, Thomas.
Thank you so much. I'll hand over back to Caroline to do some final wrap-ups of the session.
Thanks, everyone. Thanks, Josephine, and thank you to all of our presenters for that excellent session today. Just looking forward to the next session, which will be on Wednesday, the 19th of March, on the topic of dentistry. It'll be hosted by Associate Professor Leanne Teo, and we've got 2 presenters, one from the University of Manchester, Dr. Wendy Thompson, and also Dr. Smitha Sukumar from the University of Sydney. Their session today was recorded and will be available on our NCAS website and YouTube sometime later this week. Thank you very much, and look forward to seeing you at the next one. Thanks, everybody.
Thank you. Bye.
Bye.
Thank you.